Well, welcome everyone to our fall interprofessional poster session. And I'm Shelley Cohen-Conrad, Director of CECE. I know so many of you, and welcome today. Today's session, we have 70 students who are going to present today from 14 different professions, which is pretty amazing. We have 2 universities involved, UNE, obviously, but also our friends from Rosalind Franklin will be also presenting today. Hello, Sarah. Thanks for being here. This partnership has been completely amazing, and it's provided our students with great opportunities for geographic diversity and also the ability to learn from different professions that both of us don't have. So we're able to come together and share that. So it's really broadened our students' experience, which is absolutely terrific. And, you know, I can't thank enough all the faculty and advanced students who have graciously and generously been facilitators for our sessions. You have been wonderful, and we really, really appreciate you. I do want to say before I pass this on that working in teams is not easy. It is not intuitive. And so we really think it's important that students have this experience before they get into their clinical or community settings. It requires perseverance. It requires adaptability, humility, empathy, patience, and really a willingness to share your knowledge in a way that is equitable and again, generous to each other, and to listen to both each other and obviously to your patient. Teamwork done poorly can create chaos and actually create harm. Teamwork done well with intention and, like what we like to say, is smartly, benefits everybody. It benefits patient outcomes, it benefits provider satisfaction, and it works well all the way around, supporting equity for everybody. So today's posters will tell of the diligence, perseverance, empathy, humility, adaptability, and deep intelligence of the students who put them together. And let me end by thanking my crew, thanking Michelle and Chris, who are absolutely the brilliance behind this poster session, and also to the Rosalind Franklin faculty and to all of you who have participated in these various activities. And thanks as always to Lee and David for helping us with the IT, and to Sarah and Stephanie and Megan and Elise, I'm putting you in there, who have been incredible graduate assistants. So I'm just full of gratitude to everybody. And so now I'm going to pass it along to Dean Jane Carrero, who has pre-recorded remarks for you today. Thank you all.
Good morning and welcome to the Fall 2022 IP poster session. First of all, congratulations to all the participants. I know you've made some lifelong friends and colleagues. The most important thing from this poster presentation is actually not the posters. It's the relationships. It's the teamwork. It's the learning that working together and taking different perspectives to solve a problem is really what solves the problem. There's nothing in this world that can't be solved when we all get together, think about the issue, and contribute. So congratulations and enjoy your day.
Good morning, everyone. I'm Michelle Cody, the staff assistant here at CECE. As Shelley mentioned, we're thrilled to share our spring 2023 lineup of knowledge exchanges covering a wide range of topics from health and culture in Maine's fishing community to humanizing corrections through connections and collaboration with Maine DOC, from planetary health to creative, inclusive, accessible healthcare spaces, and more. We encourage you to complete our brief event interest form, which will be dropped in the chat, and allow you to view our list of spring events coming up and select the ones of interest to you. Then we'll send you Outlook appointments for those specific events directly to your calendar so that you won't miss them. Also new next semester and included in this form are 2 in-person conversation cafes, One will follow January's Martin Luther King Jr. event on the Biddeford campus, and one will follow Maine's Maine Corrections event that takes place on the Portland campus. Both cafes will allow you to have the opportunity to meet with panelists in person and have more in-depth conversation about the topic at hand. You are always welcome to reach out to us with questions. And now I'll pass it over to CECE's program manager, Chris Hall.
Thank you, Michelle. I'm here to share with you navigation tips for how today will work and to encourage you to thank you for participating in anticipation of receiving the honors distinction and using this presentation for your application on the honors distinction if you're a UNE student, and similarly for Rosalind Franklin. And thanks, Michelle, for talking about our knowledge exchanges. We usually casually refer to them as events, but this spring we're very mindfully calling them knowledge exchanges because we try very hard to make them as interactive as possible. And they will all be online in the spring via Zoom, so you can attend and participate even if you're not a UNE student. Hint, hint. So for today, this is how this session will work. As soon as I'm done, breakout rooms will open, and there will be 4 of them. So make a note of which number breakout session you might like to travel to. You will have the power to navigate at any time to any room, so you don't have to remain in one breakout if you don't want to, if you want to move around, if there are things of interest to you. Importantly, many of our presentations are for the interprofessional team immersion, which is a 5-week telehealth simulation where students are brought together to work together, form a team, and work together as teams for problem solving a case. And several in the 4th breakout session are a public health immersion where students work together on cases similarly in an interprofessional fashion. That's new this year. And so if you're interested in that model and learning more about that, you can navigate over to there. So you have 4 breakout rooms. Each presentation has 10 minutes to present. More or less. There will be a minute in between each session to give people an opportunity to move between sessions. Everyone's presentation is pre-recorded, so you'll watch the brief video, and then members of the team involved in that activity are available afterwards for question and answer and for a conversation. And it really is sort of an informal conversation about what their experience was, what they learned, and anything about their presentation that piqued your curiosity. That's the time to talk about that. You can unmute, have a conversation. You can talk in the chat. Because there are so many of you and there's only 1 hour, we had to choose a few to be represented on the live stream and the Facebook. And you can see that through the items highlighted in yellow here. And so the live stream will make its way through each one of the breakout sessions in this diagonal fashion. And everyone should end up in in breakout room 4 at the end. So when your final presentations happen in 1 through 3, ending at 12:49, be great if you could just come on over to the 4th breakout session for the final presentation and our thank yous at the end. So in that 4th track at the end, we're sending you to that presentation because our graduate assistant, Elise Parker, a occupational therapy student, traveled to Minneapolis this summer to present her poster at the National Center for Interprofessional Practice and Education. And the poster outlines the interprofessional mini grant she received that provided overdose reversing naloxone in harm reduction kits given to people re-entering our community from the Cumberland County Jail. And so we would love for you to hear more about that.
Hi, my name is Karan Menon, and I'm a first-year medical student at the Chicago Medical School at Rosalind Franklin University.
My name is Jacob. I'm a 2nd semester ABSN student at the University of New England.
My name is Jonathan, and I'm a 2nd semester social work student at UNE Portland.
And all of us were part of an interprofessional team that did a simulation where we did telehealth visits to treat a patient with long COVID. So a little bit of background on what long COVID is. It's really an umbrella term that describes a wide variety of symptoms that continue to persist for a patient after an initial COVID diagnosis. These symptoms can persist for weeks to months after the patient has been diagnosed with COVID, and they can encompass a wide variety of symptoms such as shortness of breath, headache, dizziness, diarrhea, depression, and even more. What makes these difficult to diagnose and treat is that it's still not quite well understood why these symptoms continue to persist. And oftentimes lab work and imaging can appear normal when a patient comes in for a visit. And all these factors make this just a very difficult problem to deal with. And that brings us to our patient, Amanda. So Amanda Barry Mansell is a 39-year-old female who lives with her wife, Mo, and their children out in rural Maine. And in November of 2021, Amanda was unfortunately diagnosed with COVID and had to be hospitalized. And her respiratory status worsened enough that during her stay in the hospital, she had to be intubated and placed on a ventilator for 6 days. Fortunately, she did recover enough to be extubated and was eventually discharged after a total of 11 days stay in the hospital. But even after her discharge, Amanda continued to complain of symptoms that persisted, most notably headache, shortness of breath, and a persistent cough. These symptoms persisted enough that Amanda unfortunately had to take some time off of work. And this did end up taking a toll on her mental health as she felt as though she was not able to contribute to her family, which ended up resulting in the consultation of our interprofessional team to jump in.
Our interprofessional experience began with a large group orientation that encompassed team building exercises and information on telehealth and motivational interviewing. We then had 2 telehealth visits with our patient, occurring a couple of weeks apart. Each visit consisted of 2 20-minute sessions that comprised 1 visit with a debrief in between and afterwards. And our second visit, we got to meet Amanda's partner, Mo, and we had a debrief with live feedback from our patients. As the nursing student on this team, I greeted Amanda and introduced her to our interprofessional team. During this time, I demonstrated empathy and used active listening skills to develop trust and rapport. Using these techniques, I got more insight into her symptoms and medical history. During our second session, I welcomed Mo and discussed the accessibility and effectiveness of our team's previous recommendation. As our social worker student utilized motivational interviewing techniques to develop rapport and learn about what mattered most to Amanda and Mo. Using these methods, he was able to discuss the importance and the impact of Amanda's condition on her relationships, occupation, and financial status, and provide information about different support programs available. Our dental student discussed the importance of oral health care with Amanda, including regular dental visits. He also inquired about her headaches to see if there was a link between migraines and issues surrounding the oral cavity. Our allopathic and osteopathic medical students took a deeper dive into Amanda's symptoms, performed virtual assessments of major body systems, and discussed the impact long COVID was having on her mental health. They also discussed different pharmacological and non-pharmacological treatment options that we discussed together as a team, the possibility of her coming in person for a clinical visit, an MRI scan, and referrals to specialists, including a counselor.
Working in rural communities provides challenges both for patients and caregivers. It can be difficult to access care providers in sparsely populated and underserved areas. This is where telehealth has such a great potential to bridge that service gap, and without it, a team intervention such as ours would not be possible. While telehealth brings great opportunities, it also brings some new challenges. And you can see those pros and cons listed here on our infographic. Every member of our team brought a valuable contribution to tasks for Amanda and Mo. We learned from one another the different roles that each provider can play in coordinating care for one patient. Additionally, the process of meeting at various times before, during, and after each session with the patient gave us valuable time to discuss our approach and the various ideas that we had to help Amanda and her family. Long COVID proves to be a challenging problem for many people, and it's important that healthcare providers are collaborating to help find effective treatments for those that are suffering like Amanda. This experience has helped prepare us for future interprofessional collaborations. As we enter the workforce, we are better prepared to take initiative and work together across professions to coordinate holistic healthcare treatment in our communities.
Thank you for that nice recording and good description of the case. Are there any questions for the team? If not, I have a couple of questions. What was the most surprising thing about this experience with this particular patient and simulation?
I guess I can start off with that. I'd say for me, the most surprising part was that going into it, we expected that a very large chunk of this would be spent on more of like her physical symptoms and a lot of the medications and different treatments that we would do. But we were fortunate enough to have a social worker, and we saw that some of the most insightful conversations that we had were more about her mental health and how her condition was kind of affecting her family dynamics. As I mentioned in the recording, one of the things that the patient, Amanda, told us was that because she had to take time off of work, there were a lot of feelings that she had that she wasn't contributing enough to the family. And that was something that we spent a considerable amount of time across multiple sessions diving into. That was mostly tackled by our social worker. And I thought that was insightful just because I guess sometimes we kind of overlook the human side of it while tunneling in on the medical side of it. So I thought that was good that we had those conversations.
Those are great insights. Other members of the team, do you have anything to add?
I agree with Karan. It was definitely an interesting experience and we got to learn a lot. And one of the things that surprised me most as well was the impact that it was having on her personal life, on her work life, and her relationships. And like Karan had mentioned, it kind of, I think, took the whole team kind of by surprise that our focus became more focusing on the impact that long COVID was having on Amanda's relationships and the impact on her children and Mo, her partner. Originally going into it, we were kind of more originally focused on like the medical aspect, but it quickly shifted gears towards her psychosocial health as well.
Excellent. Jonathan, how do you feel that the telehealth angle got involved in all of this? Do you think it was helpful or was it frustrating for you?
Well, Sarah, I think it was a little bit of both. And I think initially it was very difficult to connect with Amanda in the way that I am accustomed to working in person. And a part of it was because of that technological barrier, and then part of it, I think, was just because of her condition with long COVID. I also found it challenging to connect with the team members until we started to get going, and I started to see how other people were working, and then it became a very interesting and a very valuable experience. So I came into the project with, I think, maybe a little bit of a bias or a hesitation towards telehealth, which is why I kind of chose to talk about it in the presentation, because it became really eye-opening to me, particularly as we talked about the case, and our team name became, the rural respecters, reliable rural respecters. And I thought that was fun because, Amanda had a transportation issue, so telehealth was really the best means for her. And for us to be able to come together in this way, it was a very efficient use of our time, and telehealth was really the only way that it ever could have happened.
Excellent presentation, and we'll move on to the next presentation. Okay, the next presentation is also on the same simulation, the long COVID simulation. And this is the 100% oxygen team.
Title is Managing Long COVID Through Telemedicine and Interprofessional Approach. Our objective is to apply motivational interviewing techniques and treatments of a patient with long COVID via telehealth. We have a wide variety of team members from UNE and Ross and Franklin. The case background focuses on long COVID. 1/4 of those with long COVID are left with long COVID, and it overall diminishes the patient's quality of life. And the patient background, so we had Amanda Barry Mantle. She was 39 years old. Her goals are to relieve the migraines and fatigue triggered by her long COVID diagnosis, to improve her current quality of life, and to receive quality care via telehealth due to her lack of transportation. And she prefers neuropathic approaches to her care.
So for the first session of our encounter with the patient, our team went in with two major goals: to obtain a full medical history and to understand the patient's chief concerns. We had some meeting outcomes, which included taking on board patients' concerns of not being able to engage as she used to, not having the strength that she used to have, and experiencing brain fog with some of our questions. The patient also showed signs of lingering loss of smell. So we further evaluated the patient using the CECE tool just to access for depression, and the patient scored on the lower borders of the scale, which meant that she did not have any concerns with depression. So we went on to advise the patient to take ibuprofen twice a day and to try to use an ice pack to help alleviate the pain.
At our follow-up session with Amanda, our goals were to integrate Amanda's husband, Mo, who would be joining us for the session, to provide potential attainable treatment options for her, and to continue to provide support and validation for both Amanda and Mo. We followed up with how her week had gone to see if anything had changed. Unfortunately, not much had changed. Mo and Amanda both shared that they were feeling pretty frustrated and isolated from their friends and family because of Amanda's long COVID. We discussed further treatment options that we could provide for our patient that followed the naturopathic approach that she wanted, including osteopathic manipulation, home health and physical therapy to help with stretching, and even mindful meditation.
Overall, afterwards, we met with the actors and they felt that we did a good job listening to them. Specifically, Amanda said she felt treated like a human, which was huge.
From a physician assistant perspective, our biggest takeaways were that the goal isn't always fix a patient, but to provide support and validation that what they're feeling is real and that we're really in this for the long haul with them.
From the dental medicine perspective, it was definitely challenging to incorporate dentistry into a very, very medically rooted case, but it was important for me to make sure her and her family had access to care and made sure that they were being checked in on every aspect of their health.
From the social work perspective, it was important to learn how to provide appropriate resources for the patient and their family.
Overall, we respected the patient's beliefs of the naturopathic approach and found limitations of telemedicine, such as communication and interpersonal relationships forming over a screen, slightly challenging, but it was definitely an important skill to learn. And we also learned the importance of interprofessional work, as it is a hard skill, but definitely an important one to incorporate in our health professions.
Okay, thank you so much for that presentation. Are there any questions from anyone in the room for this team? If not, I will always have questions for you. What was it like developing a sort of sense of team over the telehealth with this case? How did that work for you?
I'll start off. So I think it was really interesting to not only have students from UNE, because we may be a little familiar with everyone's curriculum at UNE, maybe just a little, but having also students from Rosalind Franklin who may have a vastly different curriculum than we have. But we were one of the fortunate teams that had just about every profession available to us. We had an MD student, DO students, physical therapy, social work. So we really were able to bounce a lot of ideas off of each other, some feeling like a little more medical side, some allowing us to learn about different like opportunities and outreach programs that we learned a lot from, like our social work student that I didn't know anything about prior to this. So I really learned a lot having the opportunity to work with other professions in this simulation.
Did your team get into any sort of frustrations with each other or conflicts, or was it more like learning how to understand each other's points of view and approaches to treatment, et cetera?
I think we all came in with a very different approach to how we wanted to approach the patient, but I think we were able to kind of like mend those together pretty well overall.
Are there any things that you will take with you on your career about using telemedicine or working in a team? Sort of personal revelations.
For me, I'm the dental student, so it was a little tricky to incorporate dentistry into this case for me. So I kind of learned that it's still important, no matter what you're dealing with, that to make sure that your patient's dental health is still getting taken care of. And I found it extra important to kind of teach that to my team members, or at least I hope I did.
So there's more than one kind of learning going on here. Yeah. Okay. We have a little bit of time, and oh, Donna, do you have a question?
Yes, thank you. So Donna Hyde, one of the nursing faculty. I think it was Crystal, you had mentioned how you can have that loss of that personal relationship if you're using telehealth. Did anyone feel, and this is either case, that the use of telehealth might have been an easier format for some individuals that might not have been comfortable in a personal setting, that it provided them a different kind of opportunity to have a little safety between the provider and the client?
I think the more opportunities we can provide for our patients and more options, the more opportunities we'll have to treat them. And when they're more comfortable, it'll just make that process easier, I think.
Good insight. Well, thank you all very much. It was an excellent presentation, and we'll now move on to the next. There they are.
Welcome to our
Okay.
presentation on addressing the social needs of rural long COVID patients. This presentation was done by Lily Russell, Skylar Evans, Alina Haugen, Brooklyn Otero, Rochelle Mandola, and Julia Shepard. First, to address the problem with connecting social services and social needs in rural areas, we need to recognize how relevant the rural community is to healthcare providers in our area. Maine and Vermont have the highest proportion of populations living in rural areas at around 61%, while California has the lowest at around 4.9%. This means that accessible care is likely a concern for the majority of Maine residents and should be on the radar of Maine healthcare providers. Next, 12.7% of non-institutionalized civilians in the U.S. have a disability as of 2019. Now that long COVID is considered to be a disability and that 1 in 13 adults in the U.S. are suffering with it, we must consider how much the need of assistance will increase. We also must consider the effects of a disability on one's likelihood of developing depression, obesity, diabetes, heart disease, and the likeliness of starting to smoke. For those experiencing these factors, it amplifies the importance of providing resources to those experiencing long COVID. Pharmaceutical care is an important aspect in the spectrum of healthcare. There are several business models and service enhancements used by rural pharmacies to increase access to pharmaceuticals. One example is the use of courier services, which bring prescription drugs to the patient or to an outlying location. Rural communities have been implementing the use of telepharmacy, which is an aspect of telehealth that increases access to pharmacy services. This model helps rural pharmacies overcome common challenges, including financial difficulties related to low patient volume and to a limited ability to recruit qualified pharmacists. Telepharmacy models also help rural communities retain, restore, or gain access to timely pharmaceutical services. Additionally, there are payment assistance programs for individuals, such as the State Pharmaceutical Assistance Program, SPAP, which can help pay drug plan premiums and/or other drug costs. Children's Health Insurance Program, called CHIP, is another payment access plan to help provide children with health and prescription insurance at a reduced cost. In the case of our standardized patient, Amanda, long COVID had caused her to take unpaid time off from work and also limited her ability to care for her family due to her debilitating headaches. For patients experiencing a similar situation to Amanda's, they can request help through the Americans with Disabilities Act, known as the ADA. The ADA will assess the individual employee and determine whether their condition substantially limits life activity. If approved, that employee can receive disability through the ADA and be compensated for their time off. The ADA also notes that a person can request workplace accommodations, including restructuring duties at work, modifying the schedule to include time for rest, and modifying the work environment. These accommodations can be requested if the employee meets the ADA's definition of a disability, if they work for a company with 15 or more employees, and if the employee is qualified for their position that they work in, all of which is the case for Amanda. If Amanda ended up not being able to take complete time off from work, or is put on a wait list for Social Security benefits, these workplace accommodations could benefit her. Additionally, if a person is able to document that they caught long COVID from their workplace, they can apply for workers' compensation. It is important for the applicant to document all doctor's visits and have them print out summaries after each appointment. It is also beneficial to apply for Social Security as soon as possible, as patients tend to stay on the wait list for Social Security disability benefits for at least 6 months. During the COVID-19 pandemic, social workers played a major role in awareness and in addressing social injustices placed on powerless groups in our society. The role of social workers includes, but is not limited to, connecting clients with local agencies to help economic hardships surrounding healthcare, providing adequate social support for at-risk populations, creating awareness of how communities are disproportionately impacted by the pandemic, promoting and acquiring access to online platforms for clients such as telehealth, and advocating for the inclusion for the most vulnerable populations. The graph to the right was taken from the CDC. It illustrates the COVID-19 weekly death rate per 100,000 population in the US by county, urban and rural classification type. The yellow line is our focus as it represents rural populations. We can see that around January 13th, 2021, there are weekly deaths of a little over 10 per 100,000, and recently, it shows on September 28th, 2022, there are weekly deaths of around 2 per 100,000. Although we can see a decrease in the values, we can also see that rural communities are the most negatively impacted. For future directions and takeaways for Maine healthcare providers, understand the population you're working with. If you work in Maine and you are equipped with the knowledge that is predominantly rural, you can gear your practice to serve the unique needs of your patients. Continue to educate yourself on local resources. Be knowledgeable of local groups that you can connect your patients to that support their needs. If patients have difficulty driving to get medications, learn which mail-away pharmacies deliver to your area. Also attempt to be educated on changes in legislation, such as modifications to the ADA to encompass long COVID. Knowing what new resources are available to your patients can help break down barriers to access and potentially improve their outcomes. Ask your patients what their primary concerns are and work from there. If your patient is dealing with difficulties at work because their employer has not heard of long COVID, provide education materials about current laws and regulations regarding this condition to give to their work. Allow your patient a space to tell you what their concerns are and start from there. Attempt not to assume what their primary concerns are.
Thank you for that very informative presentation. I see we have some people from the group. There were two teams that actually put that together. Do we have any questions from the group for our team members, our presenters? If not, I will always ask a question. How did you feel about having the different professions represented, and how did that work in your interactions with the patient in this particular case? Was it an advantage or disadvantage?
I found it to be an advantage because it allowed each person to go into the next simulation kind of looking at it as like a different avenue instead. You were thinking about things that you might not really think about in the first place if someone hadn't brought that up to your attention to begin with. So like, for instance, for dentistry, I never realized how much dental health had to do with other aspects of, different avenues, like even COVID itself. So being able to see that and then take that into practice as well has been really eye-opening, and being able to look at even social work too, and just trying to build a whole picture for a patient versus just one aspect of what you're studying.
Okay, excellent. I would ask another question, but we've been asked to sort of wrap things up because we need to get to our last presentation. Thank you so much for your presentation. It was really very informative and good. Thank you.
Hello, today we're going to talk about balancing clinical objectives with patient-centered care. My name is Simran Bogle, and I'm a second-year student at the College of Dental Medicine.
I'm Jen Fountain, and I'm a first-year PA student.
I'm Farah Ressam, and I'm a second-year osteopathic medical student.
I'm Astea, and I'm also a second-year osteopathic medical student. We also worked with Emily, a podiatry student, Allison, a medical student, Megan, a nursing student, and Sydney, a social work student.
IPTE is the Interprofessional Team Immersion, a program between UNE and Rosalind Franklin health profession students to collaborate on a case and gain interprofessional experience. For the fall 2022 IPTE experience, the case was a patient experiencing long COVID. So long COVID causes ongoing, variable, and occasionally debilitating symptoms for months to years after COVID. A quarter of the patients are left with long COVID. This affects them not only physically, but mentally and emotionally. And because there's little information exactly how to treat the symptoms, it makes it difficult for providers. Due to these overall effects, physical, mental, and social, providers need to learn how to balance a patient's personal needs as well as their medical needs. Our patient was 39 years old, and her chief complaints were migraines, which was making it hard for her to go to work, and she couldn't care for her children, and she couldn't travel for care due to how far it was and due to the costs.
The influence on patient support system can be anyone. It can be family, friends, partners. We faced many challenges that the patient's spouse was interrupting our patient multiple times in a way that could discount her emotion. However, that was unintentional because they were trying to support them. The challenges that we should face, that we should keep in mind that these support system are trying to support our patient, and also they have some type of point of view that the patient themselves may not aware of that they need or have or they do. Using telehealth was very challenging because we used Zoom as a way to have that meeting. And some of the challenging through Zoom was connectivity, delay in communication, speaking on one another, also lack of in-person contact. Provider may not have a complete physical exam, difficulty reading facial expression, and difficulty making rapport with the person. Overall, team recognized that telehealth is a difficult method of healthcare delivery that take practice, patience, and professionalism.
Balancing clinician goals with patient desires. As a group, we found that it was difficult to balance what the patient wanted with what we as providers feel the patient needed. The patient wanted more homeopathic and natural remedies for her care. So one thing we did was we swapped her medications in order to cover her hypertension history as well as migraines. We also came up with several natural remedies that she could use. Overall, we found that patients are more likely to be compliant if they feel they have a say in their care. It's easier to manage fewer medications and treatments for patients, and patients like to feel in control of their care. And as providers, we found it was important to be adaptable. We also found challenges working as an interprofessional team. One of the challenges we faced was having every provider have a say in the patient's care and balancing the different providers' wants. We also found that one thing we use as an approach was providing care with the best provider for a certain complaint.
IPTE helped us to better understand that providing quality patient care means meeting the patient's needs based on their individual priorities and values rather than our own. The experience also helped us hone our communication skills when interacting with patients and other healthcare professionals in a telehealth setting. It reinforced the importance of learning from our colleagues and allowing the professional with the most experience on a specific complaint to organize and integrate care with the other specialties.
Thank you for that presentation. Are there any questions from non-team members? If not, I will ask one. You did a great job at listing challenges, both of working in teams, but also with telehealth and the situation in general, the healthcare in general. How did you deal with conflict? I mean, how did you resolve sort of the frustration of working in these different situations?
I can speak on that. So actually, we found some challenges having like a Zoom meeting or telehealth visit by difficulty having a team in the same room with the patient that's already frustrated with all of their symptoms, that everything that they are experiencing, that they have no idea what's going on in their life. So with that frustration, we decided that us working as a team, maybe we should choose a same group of people that will go during the visits, so the patient will have a familiar faces that she can recognize. And I think that idea was very helpful because the patient was able to recognize people and build that trust with multiple visits.
So there must have been a lot of discussion behind the scenes about how to handle things.
Yeah, I think to elaborate further on that, I think that one thing our team did really well is we were really good at working together and kind of piecing together what everyone wanted to do. And I think we were fortunate to have a team where we were all really good at listening to each other's wants and needs and incorporating that. And I think that the people that we picked 4 people to consistently be, or we picked 2 people to consistently stay in the room and then switched out people as needed. And I think that by doing that, we also paid attention to what the patient needed, and we were good at listening to each other to see who was best to enter the room and help the patient.
Was it helpful in terms of listening to the patient to have other professionals there also listening so that if somebody missed something, you could chime in?
Yeah, I definitely think that that was really helpful. For example, some of the complaints were feet related. So the podiatry student, it was really helpful for her to hop in and be like, hey, by the way. And then also there were things that some of the students, like Allison, she was able to look up stuff quickly and be like, hey, this is a natural remedy that I probably would have never thought of. So that was also really helpful.
So there were some advantages at least, which is great. Last question before we all navigate over to the fourth breakout room, and that is there one thing that you will take with you as sort of like a talisman or whatever for your career to say, okay, I'm working in a team or I'm working in telehealth? What's that one nugget of goldenness?
I can speak on this one. It's just that you don't know everything, and you like, it's good to know when you should like give someone else the power, be like, this is not my specialty, but I know that someone else knows exactly what to do. Like Sydney was like our team leader, but she knew like so much about like resources that some of us might not have known about that our patient could really use. So like it was nice to know like when I could step up and when I needed to take a step back.
So being humble and having appropriate boundaries. Yeah, that is like a hallmark of all of the interactions that you had, both in teamwork and collaboration, and also I think in telehealth too. Okay, fantastic. Great presentation, great teamwork and work in general.
Hi, everyone. My name is Rebecca Okanya. I am a DPT student.
My name is Cheyenne Malloy, and I'm an occupational therapy student.
And I'm Aubrey Moser, and I'm also an occupational therapy student. We recently participated in the 2022 IPD simulation experience with a simulated patient experiencing physical symptoms and personal hardships due to long-haul COVID. And we really wanted to explore further the role of physical and occupational therapies on an interprofessional team. We had a patient named Amanda who was reluctant to enlist another team of providers via telehealth and reluctant to use traditional medications. Based on her case and what she was experiencing, it seemed like therapies were going to be some of the biggest influences in taking care of her. Our approaches to treatment were to, one, identify the activities of daily living that were most strenuous and offer activity modification strategies. For example, engaging with her kids was something that was really important to her. So offering strategies to allow her to play with her kids was something that was really important. Secondly, we taught the patient how to perform pursed lip breathing in order to alleviate some of the asthma symptoms that she was experiencing. And thirdly, and probably the most important, we met the patient where she was. We offered support and resources in her community, and we continued to educate about her ongoing condition.
We sent out a qualitative questionnaire to OT and PT students that participated in this experience last year. And some of the themes that we found in our responses was that there was an assumption of roles. PT was known as working with lower extremities, and OT was known as working for with upper extremities, and this is not necessarily the case. And one other common theme was that there is an initial lack of trust and belief in others. The group, or one quote was that the group did not seem to make space for PT interventions or consider what PT could do. And another was that I had to defend OT as a profession and why we were involved in the case. So with those themes, when comparing those themes to our own experience, we did see the assumption of roles in our experience and had to explain our roles. And additionally, there was an initial lack of trust in the beginning. So when we first started, we could tell that we were all kind of acting from an individual perspective, and this quickly was known that it was not working, and we did have to pivot. To do this, we came together and we did work as a team, and we found that once we were collaboratively working, with an understanding of each other's roles, we were then able to give better client-centered care, and we also left the patient with a satisfied treatment plan.
Wonderful presentation, by the way, Rebecca, Cheyenne, and Aubrey.
Thank you. Does anyone have any questions?
I do. So you mentioned that the occupational therapy and physical therapy roles were discussed and you worked them through. And you also put it in a historic context that somehow the OT role had been designated beforehand and the PT role designated beforehand. How did you, as a team, work that out?
Like during our experience in the IFT, like how did we challenge that?
Yes. Yeah.
Okay,
How did this experience help you work that through and come to a better understanding of your roles?
Oh, absolutely. So one thing definitely was that when people came to us with what they had expected that we were, or how we were going to contribute with this case, pretty much what we did was that we would just like re-explain our position and how we are assisting with all occupations of their life, not just like job or upper extremities, or well, you had the issue with the job placement, right? In your experience? I think in my experience, like a lot of people thought that occupational therapy was really about the environment. And I kind of explained that Amanda's role, she had lost her role of being a mother, and that was something that was really important to her. And I explained that that was something that I can help with as an OT. So that helped our treatment because that was something that was very important to her. And I kind of came up with the idea of like, okay, maybe you could, she liked to read with her kids. And I was like, well, maybe you can listen to a book with your kids instead, like on low, and it won't cause a headache. But just like bringing that information because other people didn't know that like OTs help with roles of like a mother or a wife or something like that. So that was how I kind of educated my group in that area. Other examples too were just so one other aspect was that she didn't really want to start any new prescriptions. She didn't want to be prescribed any more that she was already on. So one thing also was that other physicians, when they would make a comment of like some kind of treatment plan, I would like speak up and say, well, as an alternative, we could try this and see how this works out. And so that was also another way that we were kind of informing those around us and what our position really can entail. So kind of like learning by doing.
Yes. It sounds like that was very effective for you.
Absolutely. I feel like too with the positions of OT and PT, both are very hard to explain. Both cover a lot of ground. You really can't say that in an elevator speech like we're taught all the time. Really, it's the best way to learn is to see it firsthand. And that is one thing that we think is like really amazing about the FT experience. And that was one thing that we feel should be continue more in all programs, is that just really pushing for everyone to experience these simulations just so we can all see how every department works, not just your department. And especially helps with like if you're sending out prescriptions or when you're working or collaborating with other fields.
Yeah, well, thank you.
Yes, and to address Liz's question in the chat box, it says, what do you think helps most in understanding roles and responsibilities and busting some of those untrue myths? And I think it is like what Aubrey was saying about instead of telling people, well, we're going to have to tell people what we do, but that doesn't always work. It's really coming together and seeing it firsthand and how we can just come together as a team. And once we see how OT and PT are put into different contexts, then we'll understand after we see it instead of just saying it. Because I do think like a lot of stereotypes are just cut so deep. Like it's hard, like even before I came into OT school, it was kind of like, okay, OT is upper extremity, you know, it's like hard to not think that because that's kind of what you think if you're not in school for it, I guess. Yeah, it's almost like it's like naturally ingrained just from years of being told that.
Yes, those are all important points. Rebecca's here. Rebecca, did you want to add anything to this conversation?
Yeah, I think it was really important to highlight the collaborative nature that already exists between PT and OT. I've been on a clinical rotation, so in the hospital where OT was kind of my best friend, going and treating patients. So I think between the two of our professions, we know kind of how well aligned we are, and our goals are the same, and maybe our treatment approaches will be very similar. So it was really about coming up with our own identity as a team and then explaining that to the bigger team so that they could see us kind of as a force that could help together, especially where traditional medicine in this particular case wasn't what the patient wanted. So why not utilize a different method of treatment that may be more beneficial? But first we had to kind of explain what we can offer as a therapy for the patient.
Great. Thank you.
Hello, my name is Nikki Barrington, and I am in the allopathic medicine program at Chicago Medical School. And today I will be presenting a poster with Kim DiGregorio-Roth, who is in the Applied Nutrition program at the University of New England. Today we're presenting our poster entitled Interprofessional Collaboration to Overcome Patient Hesitancy and Increase Engagement. To start off with, we want to introduce you to our simulated patient, Amanda. She is a 39-year-old woman that has a history of hospitalization for COVID-19. At the time, she presented with severe cough, headache, high fever, and an 85% oxygen saturation level. She then spent 11 days in the hospital. 6 of those were on a ventilator. While she was in the hospital, she was diagnosed with hypertension and prescribed lisinopril and an albuterol inhaler. Since her discharge, she has struggled with long COVID symptoms, including fatigue, migraines, loss of taste and smell, poor appetite, and occasional bouts of coughing. Those symptoms have been really difficult for her to manage, and so her main goal is better symptom management, preferably using natural remedies rather than traditional medicine, so that she can get back to both her work and home life as usual.
Our team was able to meet with Amanda for 2 separate sessions. Each we had very different goals for each session. Session 1, we came in with a very set agenda. Our plan was to come in our very separate areas of expertise and offer Amanda what we thought she probably wanted. There was little collaboration with the patient, with Amanda, and with each other as a team. And in the end, the patient was very overwhelmed and hesitant to try anything. During the break between sessions, we were able to decide to focus on the cues that we had gotten from her during session 1, namely that she was interested in all of the natural options that we had to offer. So this time, specialists each went in focused on that same goal, the goal of natural symptom management. When we did this, we found her much more receptive and encouraged and even eager to try some of the recommendations. We also included her partner, Mo, as part of her care team, which was helpful. At the end, our nursing student went in to provide some counseling and just an empathetic listening ear to Amanda and Mo, and they very much appreciated that as well.
So our main takeaways as a team from this were how important it is to gain clarity around a patient's goals, to reduce their hesitancy and increase their engagement with their own care. And secondly, how important it is to be able to pivot to better meet a patient's goals in trying to provide patient-centered care. And most importantly, showing the patient that you hear, understand, and believe them is incredibly powerful for both the patient and the care team.
Okay, Stephanie, moving on to conversation. Well, Kim and Nikki, again, excellent presentation. And I'm so impressed with what you were talking about, following cues from patients. But other people, do you have questions first? I'll get to mine then. So this following cues from the patient, I think you did a good job on your poster describing how that awareness grew, that you really needed to listen to the patient. And can you talk a little bit more about the process of your own awareness? Kim, I'll ask you first. That we need to make sure we're listening to the patient.
I think in session 1, several of the team members, even you could just visibly see when they were to mention some sort of pharmacological approach to symptom management, kind of like a even step back from the camera from the patient, which gave us a clue that she kind of wasn't really interested in that. She also did a lot of like, I don't know. So it was like vocal in what she was saying. It was in her body language, how she was kind of backing away and kind of growing wide-eyed. those things kind of clued us in as time went on that she was not interested in those things.
Thank you. How about you, Nikki?
I completely agree with Kim, that there were a lot of sort of nonverbal cues from the patient that what we were saying wasn't really getting through to her. And for me, it was really a good learning experience. And, you know, my previous interprofessional experiences, I've learned that often the MDs are kind of made the center of the room, whether we want to be or not. Often that's the case. So a very good lesson in how to step back and let those other professions help her in a way that possibly, you know, traditional allopathic medicine couldn't help her.
I think that's a very astute self-awareness, Nikki. You know, and to be able to step back is challenging. Other elements of this experience that you thought were important that for the audience here to know about?
I think the most important thing really was how much the patient's demeanor changed, particularly when our nursing student really took the time to say, you know, we believe you, particularly with long COVID symptoms or other similarly kind of invisible illnesses, so to speak. Patients interact with a lot of healthcare professionals and they don't necessarily feel believed about what they're experiencing. So how big that was in terms of getting her to engage with the care, just expressing that empathy and that we believe everything you're saying.
I think too, oh, sorry. I think too, being able to almost like onboard her partner as like a, you know, a teammate in her care ended up being really great too. The difference between not having him present during the first session and then having him present, even when she was maybe starting to feel overwhelmed, he kind of like would step in and be like, you know, yes, we can make that happen. I can do these things. And I think seeing them as a team really felt like it made a difference too in her care moving forward, is what I would imagine.
Excellent. I'm glad that your team had that experience. Yeah. Okay, I think it's time to move on. Am I right, Stephanie? Sorry that this is so quick. We could go talk about each one of these presentations for an hour.
Thank you.
Thank you.
Hilton, and I'll be presenting our poster on caring for a patient with a chronic disorder. I'm a student nurse in the ABSN program at UNE and worked with Joshua Smezdad, PA student at UNE, Elena Hagen, and Michelle Dupree, both UNE ABSN students. We were part of the long COVID IPTI event with the standardized patient, Amanda, and were supervised by Dr. Paul Segal. As we know, care for chronic disorders requires multiple parallel care processes, which puts patients at risk for fragmented care, decreased adherence, and increased healthcare costs. As we saw with our stimulated patient, Amanda, long COVID is no exception. Amanda is a 39-year-old woman hospitalized in November of 2021 for respiratory complications related to COVID-19. Ultimately, she was intubated for 6 days. Since her hospitalization, she has had lingering symptoms of brain fog, shortness of breath with exertion, fatigue, and debilitating headaches. She's experienced a significant decline in her quality of life since then, related to these symptoms, and she states that she just wants her life back. Amanda was frustrated with her lack of progress. She was experiencing low self-confidence related to her family role, and she was burdened financially by her healthcare needs. To overcome these obstacles as a team, we approached Amanda's case with a staged approach to provide a holistic plan of care. So we identified her first priority and created a clear, attainable treatment plan, incorporating specialized healthcare team members when applicable. Once that was being managed, we explored her next priority stepwise, tackling one at a time to prevent the patient from getting overwhelmed, which is a very common occurrence with chronic diseases. So by setting focused, short-term, and achievable goals based on the client's context, we created motivation, optimism, and progress for Amanda. Further research has shown that the chronic care model and goal-oriented model are both effective approaches at managing chronic conditions. They aim to bolster the client with an emphasis on autonomy and collaboration. Through this IPTI experience, our team learned that by implementing a more holistic, client-oriented approach through both interprofessional and patient collaboration, we had the potential to improve patient experience, reduce healthcare costs, improve population health, and increase provider well-being. Thank you.
Questions from folks or participants, comments? Tell us about your thoughts and feelings about the chronic care and goal-oriented models, or anything else that you want to comment about this experience and how it brought the team together.
Yeah, well, because of how the model's designed, it almost like forced us to make sure that we're all or saw each other all on the same playing level. And actually our first interaction with Amanda, we actually had it led by the PT instead of like coming in with our allopathic doctor or myself as a PA. We kind of wanted to make sure Amanda knew that we were more focused on her and what she thought she could do and on the realistic like possibilities for her, instead of being like, all right, can you pay for this drug? Can you do this? We see that you've had these like complications. Like instead of forcing something to her, we wanted to ask like, what does she think she can do? And it really helped us focus on like her migraines, because we let her talk and we listened, and she said like, this is the biggest problem because I can't hang out with my kids. I feel like I'm failing my husband. And that's where we took our first step, was for those migraines.
Great, thank you. So there was a question in the chat about these two models, and the questioner was wondering, are there other models that you considered, or other models that could be used that you as a team considered?
We had actually really just focused, because we knew it was a chronic condition. So when we were doing our research, we looked for chronic care models. And we hadn't really come across anything besides this one, at least that had like research proving that it worked. I mean, we could have taken like more of a traditional approach, which is like, here, let's try maybe your albular hair, or let's give you like a llama or LABA combo, like let's try something else. And then maybe try to give her even like a COVID medication. And that's more traditional if it was just one provider, instead of being like, here, let's talk to PT, let's work on your breathing, let's do these exercises with OT, let's have them come to your house, maybe let's try to get a social worker involved. But nothing specific that we really ran into besides this chronic care model.
So it sounds like that though you did your research, these were the models that fit, and they were successful in bringing the team together, you said.
Yeah, absolutely.
Yeah, in your debriefs during your IPTE experiences, what was the process like there, Joshua, with regard to people's growing awareness of what this patient needed?
Yeah, so our debrief was, a lot of people had agreed that like the migraines was the most important thing, and that we had to focus on that, and that it wasn't just like a pharmacological aspect or approach, but that it was more like, let's get you moving around, because that's realistic for her. She was, I think, 45 minutes away from from like her PCP. So instead of like trying to make her drive, and she had a truck and that costed money. So instead of like having her come into the office, like what could we do for her that first visit, for like those first couple of weeks before our next visit, that she could start to see some improvements or kind of have some hope. And that's what I was like touched on, was that we gave her something to hang on to and do once leaving after that first appointment. And she was super receptive to that, obviously, because she knew that she'd have to come in, she'd have to waste any money, but that these are things that she could, do for herself.
Wonderful. Well, so that to me, that identifies a lot of awareness that was growing on your team. Since you're the only one here, you get all the questions.
Absolutely.
And you're doing a great job. The other question I had for you was, what will you take from this IPTE experience with you into your professional career as you move on? Do you think? Have you speculated on that?
Yeah, I want to know my resources, and I want to know like what other providers, who they use and who they refer to, because I think more and more that is medicine. Like medicine is no longer seeing one person. or just one specialist. It's seeing like a range of people. And although it can be complicated with like insurance, I think that's where we're headed. And so we kind of have to adjust financial aspects to that, because you need to see other people to get their perspectives and what they can do for a patient if something doesn't work out. Because obviously we had talked about like the way a PA or an MD or a DO may see something is different than the way a nurse or a PT or a social worker or an OT or anyone else may see something. So
Yes.
that was probably the biggest takeaway, is that we need to know our resources. We need to know who we can refer to and who's around us, who's local. And I think that's
And
probably
with
the biggest
whom you might want to have a consultation with around and join the team, perhaps, if they could.
Could you repeat that?
That you would refer, but also get consultation for the team from those professions, if you can. It's not always possible, but
yeah, that was something we did say. Like, rarely could we get like all 6 people on a Zoom call with a patient, but it worked out really well. If we could do that in an ideal world.
Well, Joshua, thank you so much for carrying all the responsibility, and our time was up. We need to move on, and great job. Thank you.
Yeah, thank you.
My name is Anik Mitul Eyang. I'm a Master in Public Health student. I was glad to bring out my experience through an interprofessional team in telemedicine settings to help over a patient named Amanda. Through this FT experience, I learned to apply, and through this FT experience, I learned how to bring out my public health knowledge and share my point of view with different specialists. It was an amazing experience, and I want to thank my faculty tutor. Finally, I want to thank Amanda, our standardized patient, who allow us to practice our knowledge. And all through Amanda's visit, we were able to set up integrated medical plan, combining a medical approach and a non-medical approach based on the research of community resources, able to help her aside of her treatment plan. It was a great experience, and I highly recommend all students to at least experience this once in their education. Thank you.
And thank you for taking on the task of presenting your team by yourself, your team's experience.
It was challenging.
I bet you did a wonderful job. Thank you.
Thank you.
And you were very gracious in your team. So what is your takeaway, Anik, from this experience in IPTI?
As a public health student, I was like, oh, what can I bring out to help over to find a solution to solve patient's problem? Because it was when I saw the patient, I read the patient case was only focused on a medical condition, and that's it. I say, okay, as a public health student, what should I do? How can I help? And it was very interesting to, by practicing the motivational interview, I started to record all our needs, and we went through, it ended up with a medical approach and a non-medical approach. And it was very interesting. I made researches about all the community support you can have in our neighborhood,
And she was so happy to find that we are not only focused on her medical condition, but we help her to go through a chronic disease by helping her over finances, housing, try to find if she's comfortable at work. So it's like all the thing around, and she was very happy to through these approaches. Yeah.
Yes. So multiple approaches and multiple problems to be looked at. Issues,
Yeah.
yes. Well, thank you. We have to move on to we're supposed to go to track 4 now. I mean, breakout room 4, excuse me.
Okay.
But thank you so much. And again, apologies for the technical issue at the beginning.
Okay.
Wonderful job. Thank you.
This presentation will be on rural patient care and interprofessional team approach. The interprofessional team immersion, or IPTE, activity for this fall presented a simulated patient with long COVID symptoms. Long COVID has been observed recently with the COVID-19 pandemic, and this can present like breathing problems, mental fatigue, migraine headaches, and also mental health challenges. And our patient lived in a rural Maine community. Healthcare students from osteopathic medicine, physical therapy, social work, nursing, pharmacy, physician assistant, and dental medicine, all from the University of New England, were tasked with treating this simulated patient by working as an interprofessional team in a multiple discipline approach. Students met with each other and the simulated patient over Zoom for 2 hours for 2 sessions. Between sessions, the team had opportunities to discuss the case and collaborate on potential solutions for high priority needs identified by the simulated patient. So this really presented us with an intersection of real life challenges. The IPTE team, we really had to consider real life challenges that this patient faced, including healthcare literacy, financial impact, social needs, and available resources. Access to adequate health care is a problem that many people in rural areas face, especially in parts of northern New England. People in the affected areas can face difficulties traveling long distances to their appointments, accessing prescriptions, and getting referrals to other providers that may not be in their area. Many healthcare disciplines are trying to help this issue by implementing telehealth practices, but there's still a large gap in the treatment of people in rural versus urban communities. Since the COVID-19 pandemic, these care discrepancies have been seen on a large scale in Maine. Patients experiencing these long COVID symptoms present a new challenge to healthcare providers around the country, but especially if they're from a rural area and they have that access to care challenges as well, like in Maine and like our simulated patient experienced. So each team member provided expertise on their discipline, and based on patient feedback, demands for assistance from some disciplines were greater than others. For example, the patient had pressing economic needs that eclipsed other important areas that needed to be addressed, such as nutrition, workup for long COVID, and dental care. However, regardless of the discipline, all the team members remained engaged in planning and decision-making to determine the best course of action to meet patient needs and adhere to a patient-driven care plan. So for the first session, the team introduced ourselves and gathered a patient history of presenting illness and obtained information about the simulated patient's environment as well as their financial and social situation. From our first session, we identified 2 main issues based on the information we were given. One was the impact of the illness on her daily living and the financial impact on her family stemming from a lack of resources and their rural location that they lived in. The team discussed how to approach the patient's needs and what resources and treatment we could recommend. Each discipline contributed their expertise to the plan, and then we presented the plan to the simulated patient at the end of that session. For the second session, we followed up with the simulated patient and her partner, who was also an actor simulated patient, and evaluated the effectiveness of our previous plan from the week before. We were able to reconvene and adjust our approach based on the feedback we received Ultimately, we were not able to address all of the issues we wanted just due to the timing, but we gained valuable insights on how to approach patient care from a team approach. Our simulated patient and her partner gave us feedback on our performance after both simulated sessions. It was difficult during the first session to make a connection as we were still trying to figure out what issues to address. One takeaway was to spend more time recognizing patient emotions and forming a healing relationship with her. As the first visit, we really had to focus on getting the facts of her medical history, and it was a little bit stiff of an interview, and we didn't really get that personal connection we were hoping for. Another was to streamline our intake process to obtain the information we need in the time that we had. Our simulated patient told us we did well to identify her needs and make her feel heard, especially during the second session. That was something that our social worker did. And overall, I think it was a learning curve to manage what little time we had with the patient against the many interventions and the resources the team wanted to provide. But having everyone give their input and what information they could provide based on their own discipline gave us a lot of work to help with the patient. And so overall, we had a really great time, and we learned a lot about how everyone on different healthcare disciplines can work together and really create a streamlined care for our patient that would help her not only with the medical issues, but also the financial, mental health, social work, all of these issues kind of coming together that contribute to a condition like long COVID. And we really helped our patient make it better and help her feel better towards the end of the session.
So that was wonderful. That was so well done. Thank you for that.
Apologies for the audio blips. I learned that I cannot screen share and mute at the same time.
There we go. There we go. Lesson learned. So does anyone have any questions or comments?
Karen, can you talk more about what happened in each of your sessions a little bit?
Yeah, definitely. I'm actually glad that you asked that question because I realized in our presentation, we didn't go into super detail about each visit. I kind of was focusing more on the global things that we learned, but I think that is an important detail to add. So very generally, we had 4 patient visits and both were pretty short. So it was kind of hard to fit everything in all at once. But our first patient visit, it was a lot about getting their medical history, and we kind of just decided to focus on her headaches that she was having, migraines, and she has trouble with asthma. So we focused on changing up her asthma medications and then headache relief. Our second visit, it was about getting care in terms of, and our social worker helped us a lot with this. So it was getting her medications mailed to her or getting transportation help. And then we also helped her set up mental health counseling because she was having some anxiety and depression symptoms as well. And then our third visit and kind of the fourth visit as well, it was with her husband. So we focused on her symptom improvement and then also getting food and clothes for the children because they had just started the school year in the simulation and they didn't have clothes. And I thought it was pretty interesting because in our third visit, it had supposed to have been 2 weeks between our simulated first visit and second visits, or third visit, I guess. So the patient said, oh, my medication didn't come in the mail. So I don't actually know if the medication helped or not. And we were kind of annoyed at that, but I think it actually was a very real life scenario that would happen. So it was kind of helpful to be like, okay, so we don't actually know what helped. So let's kind of reconvene and try to redirect a little bit. And then our fourth visit was really focusing on physical therapy for her migraines. I'm a dental med student, so I kind of felt like this is where I could help a little bit with migraines and possible temporomandibular disorder, things like that, like jaw issues that could be causing migraines as well. Because before that, it was really heavy with social work and osteopathic medicine and also physician assistant, kind of getting that medical history. So I felt like we could actually help a little bit with this. And our physical therapist, like, actually moved his camera, got down on the floor, was doing neck exercises. It was really funny. So, but it was really helpful for the patient too. So
thank you for that.
Yes, that was great. So I think we need to move to the next one.
Thank you.
Hello, my name is Pritika Sharma and I'm a part of the OT program.
My name is Jessica Sharma and I'm part of the School of Pharmacy.
Hi, my name is Gabriella Thompson. I'm a part of the nutrition program at the Westbrook College of Health Professions, and we decided to do our poster on interprofessional approach to diminishing minority discrepancies. And the research question that we started with was, what steps can professionals within the healthcare field take to diminish discrepancies faced by minority groups and improve the health outcomes for these communities?
We wanted to highlight for the introduction that discrepancies among minorities have been an obstacle for proper healthcare for many years, and it's our job as health professionals to combat this.
Some statistics we found from the CDC was for most cancers, African Americans have the highest death rate and the shortest survival rate out of any other group in the United States.
And for some studies, we found a meta-analysis compared health literacy and adherence. And then we also found something with COVID and race, and combining those together, there were some race issues and proper care not being met between all patients.
And some reasons for these health discrepancies are driven by underlying social and economic issues that are rooted in different social determinants of health. For example, socioeconomic status, education, and healthcare.
So some solutions we found for these discrepancies was firstly to improve cultural competency within the healthcare field. So basically developing our overall knowledge of certain cultures and groups, and limiting self-bias, and just having better awareness for other cultures, values, morals, to create empathy for these communities.
And another course of action we can take when dealing with patients with lower levels of English proficiency is combating this with use of non-medical jargon. Medical jargon can kind of make a sense of confusion. So by not using this, we can have better understanding with our patients and clients.
And providing adequate language translations is very much key for a lot of patients that do not speak English. And I think also leading into that, some profession concentration solutions that we can use as pharmacists. Personally, we do a lot of medication consulting. That means explaining what the medication is used for and the ins and out of the medication. A method we could use is the teach back method that basically states patients will summarize what they understood from the consultation, and we can provide help by filling in the gaps and providing proper adherence.
Another way physical therapists can combat this is using physical examples rather than stating things. Also being culturally competent, so being aware of a patient's comfort level, working with opposite sex, and understand that some exercises may need to be modified.
So in the field of nutrition, we can really do our own research on how on different meals and different cultural dietary restrictions and inclusions. And we can also ask our patients respectful questions on their familiarity with certain foods and food groups and food practices. And we can also provide visuals and just extra information on foods that they might be less comfortable with to improve their treatment plan.
And just to summarize this all, we hope these are some ways to interprofessionally approach diminishing minority discrepancies between our healthcare system. Thank you.
That was fabulous. I want everyone to hear me say that. I want to open it to questions or comments. Well, I'll start, unless you want to start, Belle.
I am so in awe of this poster. Absolutely incredible. I have a question. So I'll preface it by saying I just recently was on a grand round where the provider talked about doing qualitative research with the Hmong population during their residency. So the Hmong population was seeing that a huge rise upon immigrating to the United States for cancer, different kinds of cancer. And so this provider started asking the question, where do you think cancer comes from? And the Hmong population, not that it's a monolith, was saying, we think that the cancer is invented by you American doctors. And that's because there is no word for cancer in the Hmong language. And so my question is, you gave such great examples of how to teach back, to use examples in food from someone's culture. How would you explain prevention when something doesn't exist in someone's language? And I know sometimes that's like outside of our scope of practices.
Yeah, I can help try to answer that. So even within my own family, I'm Indian and my parents immigrated about like 20 years ago, I'd say. And a lot of things that are very common in the US are not common to them. Like they actually didn't really understand that diabetes, occurs from from sugar, but they didn't understand that unfortunately carbs are sugars too, because when you think of sugar, you think of a candy bar, not like rice. And that's also why that Asian Americans are at a higher rate for diabetes, because rice is such a key part in their diet. They're vegetarian for Indian Asians anyway. So I believe a way of explaining that would be, showing the breakdown. That's what I did with my aunt. I showed a breakdown of actually how much sugar goes into a rice and how much sugar is in a candy bar. And I think just slowly working with them and explaining to the best of our knowledge, and repetition is key as well. That's how I would approach that for something that someone may not completely understand because it doesn't exist.
I can jump into, I
Thank
think
you.
also, oh, sorry. I think it's also really important, like Pradika was saying in our presentation, that we steer away from using medical jargon. So a lot of, I think using terms that people aren't familiar with, especially those who aren't familiar with the English language, can be really harmful because people just don't know. So I think as health professionals, it's really our job and our responsibility to kind of go an extra step and do our own research on our patients, just so we can best cater to them, because we can't expect everyone to understand the words and the terms that we use. So yeah, I think finding ways and talking in ways that people can understand is really important in terms of explaining things and using things that they're familiar with.
Other questions or comments? I want to just suggest to you that you submit this to the next interprofessional conference. It's an incredible poster and a much needed topic. And so if you want some leads on that, just get in touch with us in our office and we will make sure you get that poster there. My question is about curriculum. How much of this information around cultural humility, cultural sensitivity, responsivity, whatever you want to say, is in your curriculum, and what advice would you have for faculty who are developing curriculum?
So I know for the pharmacy program, we actually had a portion of one of our classes dedicated to relating COVID and minority populations. We focused on food deserts and access of care. So I think it is built into the pharmacy program quite a bit, and I'm very thankful for it, because there are certain perspectives that I never even really thought about until taking that class. I think it's really important as health professionals too, because we're not always going to be serving the same kind of patient, so.
And also I'm a part of the HOAS program in Biddeford, and in our curriculum, it's almost in every single class we take. So for consultation of wellness, we always put some type of understanding that all our patients are going to have a different background, and it's really important that we cater to them individually because every patient is different.
I think also kind of on a faculty side, I feel like it could be really helpful to bring in guest speakers or people from other cultures or different backgrounds who can actually bring that sort of perspective, because there's only one professor and they can only speak so much to certain things. So I feel like guest speakers could be really helpful. I haven't had any guest speakers or anything in my classes, but I feel like that could be something that could be really helpful.
It's a great suggestion. Thank you so much, you guys. We're going to move on to the next presentation now.
Hi, everyone. This is our project on Social Determinants of Health Month and a collaboration of interprofessional education on care for future patients. These are the participating members and their credentials below. We reside in the UNE COM and social work programs. Our initiative here was to collaborate with the graduate and undergraduate program here at UNE to talk about and have conversations about social determinants of health and how accessibility, equity, and diversity play a role in healthcare and accessibility for patients, our future patients. Our goals of this collaboration is to foster important conversations about social determinants of health and to train future health providers and spark interest in social determinants of health and provide an opportunity for people to collaborate and have conversations about these important topics.
The Social Determinants of Health Month happened in October 2022 for the UNE community, hosting 21 in-person events, 7 virtual events, and 3 month-long events. To promote and market these events, Social Determinants of Health Month organizers partnered with the Interprofessional Student Group and the Center for Excellence in Collaborative Education from a marketing and outreach perspective to garner more support and participation.
In terms of participation, we saw that 90% of the attendance was from the UNE College, as well as 3% from UNE Social Work. We also saw that on average, participants attended 4 to 6 events, while some even attended as many as 10 events. Some of the feedback we got back from our survey included, I was deeply moved by each of the presentations I attended, and I feel better prepared for the possibility of treating patients who have encountered different types of trauma in their lives.
With regards to limitations and future plans, we want to lift up the theme of accessibility and inclusion. Our survey was not given out at the attendance of every event, and we want to in the future make sure that this is part of the process. We also know that once everyone is under one campus, the equal rotation of events will be less important. But right now, an equal rotation of events between the Biddeford and Portland campuses with an online component will make it easier for people to attend events. We also would like to lead the leadership team for next year a mass outreach plan that makes things more streamlined moving forward.
We would like to thank CECE as well as the Office of Research and Scholarship. We'd also like to thank all the Unicom clubs and organizations who participated, as well as the COM RSAS. Thank you.
Okay, so I see we have a lot of members of the team here, and I'd love to just open it up for people to ask you questions. But my primary question is, how are you recruiting to continue this really incredible project? It's critically important. We've heard from our last poster presentation the importance of understanding, and the first one as well, that social determinants of health and awareness is really critical. So love to hear from you.
Yeah, I think a big thing that we talked about moving forward is to, again, just continue the spread of this idea and have it be something that people are looking forward to throughout the year. Even though not a lot of the other graduate programs were able to attend, they still were aware about this initiative, and hopefully within the next year they'll have it on their calendar coming forward and be able to look forward to the different events that we host. We hope to keep this initiative here at Unicom strong and have the clubs that participated this year also participate next year and host maybe diverse and different events that they see fit, and then as well as reaching out to the undergraduate program, which I feel like we didn't accomplish as much this year, and hopefully reach out to key groups and allies within that college to work on events together and help spread this initiative throughout all of UNE.
I'm going to pick up where Julian left off too and touch upon Elizabeth's question in the chat. One component is that there are so many different professions represented here at UNE. And when we started talking about social determinants of health, we realized that a lot of people were replicating similar behaviors and efforts across the university. And so we were hoping year over year to create champions of social determinants of health at the faculty and staff level that could talk to students and their classes and gather support that way. And then that way, if someone was doing a food drive over here in pharmacy and someone else was doing a food drive over here in social work, as an example, that they could partner together under the umbrella of social determinants of health on both campuses. To touch upon what Elizabeth asked, if something was really impactful over the entire month this year and last year, I think just people talking about social determinants of health and connecting the dots. So, for example, understanding the vulnerabilities of someone experiencing homelessness, and that the most requested item is socks followed by underwear, was so simple and yet so kind of like earth-shattering to me that you don't give away used socks and underwear. Of course, it's because it's not sanitary. It's a low cost item for us to pick up, talking about it. And so while we do know that most of us are living on a budget as graduate students, asking someone to just pick up another pair of package of socks or underwear while we're all gathering and listening to a lecture on trauma and prevention was really impactful for me.
I can
also,
Sorry, Catherine.
I was
can
just going to say,
Go ahead, Catherine.
oh no, I was just saying with planning, one thing that I found surprising was that nearly every group within our College of Medicine had a talk that could be focused around social determinants of health. So that was just something I found really cool this year.
And in another vein of planning, Asteja and I worked to plan and bring in an outside speaker, and it was really encouraging to see how many community providers and professionals were really willing and hungry to make time in their busy schedules and professional lives to drive and show up on campus and share their work with us. And I think that kind of engagement speaks to there's a lot of people working in social determinants of health areas that want to get in front of students, and this student-led initiative is a great opportunity to invite them in.
How
Yeah, I
much
just
time?
wanted to add, oh, sorry, Shelley.
Okay, go ahead. Go, Julianne. I want to make sure we had time.
Oh, I just want to say it was really great to see how many people were passionate about this and are looking forward to learning more. And I feel like this initiative is just. Hi, everyone. This is our project. This initiative is just like growing more and more each year. It started only 3 years ago, and it's becoming such a big thing on the UNE campus. So I'm just excited to see where it goes next year within all the graduate programs.
And I love Liz's comment. I love that SDOH can be one of the many ties that bind us together. So what a wonderful unifying project. I'm so thrilled that it's being passed on to next year. And if folks have different kinds of ideas about projects involving social determinants, we have many grants, just putting a little plug out there.
We are presenting on physical therapy and pharmacy students' perceptions of interprofessional collaboration when working with the older adult population. Research shows that early exposure to interprofessional education is lacking in healthcare professional school. Studies show that with increased awareness of interprofessionalism, students have increased confidence in their ability to participate in multidisciplinary care. Students that don't participate in interprofessional education tend to make ethical decisions solely based off their profession-specific education. This project was designed for Doctor of Physical Therapy students and Doctor of Pharmacy students to participate in interprofessional care of older adults in a mock clinical scenario. Older adults came in and got their vitals screened by physical therapy students, while the pharmacy students reviewed the person's med list. The students then collaborated and gave their best recommendations to the older adult. Students took a survey following the event that encompassed 3 pre- and post-event questions. Students rated themselves on a Likert scale for the 3 questions. In the top graph, you can see how the students rated themselves on their level of comfort participating in the overall interdisciplinary care, their level of comfort with communication with a multidisciplinary team, and their level of comfort when educating their patients on healthcare professionals' roles prior to the event.
The bottom graph displays the following the mock clinical scenario, students' perceptions on their ability to participate within a multidisciplinary team, communicate with this team, and communicate with their patients increased roughly 24%. Based on the data that we have collected, we found that there is an increasing benefit in mock interprofessional collaboration among students. Students benefit from development of deeper understanding of other medical disciplines prior to clinical experience and allows for a facilitation of cohesive care. This project has shown that there should be continued encouragement for interprofessional collaboration among UNE health professionals. We would like to thank our physical therapy faculty for their guidance on this project, and thank you for taking the time to watch this video. We look forward to answering your questions.
Very nicely done. So I saw, Benjamin, you were on there as well. Is that correct? Would you like to add anything with your colleagues?
I'm just so happy that I was able to be on this poster and really help out the PT students. I personally learned a lot, and I know that all of my pharmacy friends that were at the event learned so much. Even though we may be early in our careers, it was just so insightful to, see a different perspective on how people approach patient care and how different professions kind of see things that we may not. That was an amazing event.
Great, thank you. Thank you for being put on the spot. So again, I will reach out and see if anyone has questions or comments. I'm just excited to hear, and I wonder if you can tell us a little bit about what you know about the excitement of students wanting more either simulated or mock experiences, while they're learning, while they're on campus. Can you tell us a little bit more about that and what you felt were the real benefits of it?
Yeah, so I think one of the big things that about this whole event is that we wanted to get us and our faculty wanted the students to have more of an experience working in a multidisciplinary team before going out on rotations where, you get thrown in to rotation and you go to grand rounds and you're kind of like, oh, I don't really know like where I belong, like in these scenarios. And so having this event where we worked with pharmacy and there was a couple nursing students there as well, helped the students kind of get early like understanding of kind of how that process works. And then, as we go further in our education at UNE, we get kind of like during class, they explain like, oh, this is what you need to say when you're in a multidisciplinary team, but getting the experience where you've already been in it. And then when you're further on in class, you can learn more about, oh, like this all makes sense now. So I think the students like in their first year were excited to just have a more foundational understanding of like where they're going to go from there.
And I'd like to kind of add on to what Alyssa said. One of the big things we saw as well was the growth in, understanding where our own profession fits on a team. And I think that's just as important as knowing what other professions do, because it's hard to know what your roles, it's hard to be able to understand someone else's roles before you really understand your own roles. So I thought that was significant as well.
I have a question about how this interaction, it was faculty led initially, but then you guys took it to a student mini grant, and how that really, I think a lot of us want to work interprofessionally on these projects that are student led, but it's hard to make the connection. I'm curious what that process looked like to invite other programs in.
So for us, I guess it was more of something that was pitched from our faculty members, and coming from both of us just being on clinical this past summer in this in hospitals, I think it was something that we saw as we needed more exposure to it prior to that. And so I think as faculty, kind of bring leading discussions about what we've seen once we've already gone on out in the clinic, kind of stimulates us being able to show like what things could be added to different curriculum to foster better learning.
So I have another question. Is that all right? You chose an aging population to work with under the umbrella of social determinants of health. And I think aging is not always seen as an area in that domain. So can you talk about selecting that, or maybe it was selected for you, but what did you learn about vulnerabilities and strengths of aging populations? One
vulnerability that I kind of saw was people that may be living in nursing homes or community homes. A lot of these patients do struggle with their mental health. You kind of think of it in a way that, it's not the greatest place to live, but a lot of people do say that the community is such like a great place for these people. And we found patients that were actually struggling with living in the community. And I thought that was a very impressive that patient opened up and talked about those vulnerabilities, and that we were able to kind of make some recommendations there on how to maybe turn that around or improve their mental health.
There's a question in the chat. What components of the mock interaction do you feel will most significantly transfer from campus to practice and or clinicals? And we have about 3 minutes left, so go for it.
I can talk about the PT part. I don't know if Ben has any pharmacy things, but what the PT students did, they ran like a vital screen, so heart rate, blood pressure, all that kind of stuff. But they also did like a gait speed test, and so they had to perform physically all of those things on their older adult, and then also they had to like in the moment, figure out what the results were, and then be able to explain to the patient like, oh, your blood pressure was whatever it was, and maybe it was a high blood pressure, and then they had to explain to them what high blood pressure meant. And so I think the most meaningful aspect of it was giving them that time to like think right on the spot, because we practice like taking blood pressure on each other and our other classmates all the time, and generally everybody's healthy and our blood pressures are normal, and so you don't really have that opportunity to be able to be put on the spot and be like, now what are you going to tell someone? Or if their gait speed is a little bit slower, like what does that mean for them walking in the community, stuff like that. And so I think just them being able to be put on the spot and explain to a real person kind of what the results of their test were is the most meaningful thing going into clinical, because you're going to have patients that have no medical background and have no idea what high blood pressure means or what gait speed even is. So giving them an opportunity to explain that before they go out into the real world, I think is beneficial.
Great. Yeah. And to go off of that, it kind of gave them an opportunity as well to learn how to build rapport differently than building rapport with classmates or other faculty members as well.
Mm-hmm.
I know we've only got a couple seconds left, but I couldn't agree more with what Alyssa said, and Georgia as well.
Thank you.
Well, thank you. Wonderful presentation, and we'll see you in track 4.
Yes, so this
Thank
track,
you, everybody.
Navigate through breakout rooms to track 4 for our final presentation. Well done, everybody.
Well done.
Welcome to all the members of this CECE event, including the interprofessional student and faculty involvement. This is the Blanket Project, and we worked on building community through comfort.
This collaborative service learning project involved a team of Bachelor of Science and nursing students from UNE's Portland and Biddeford campuses with the assistance of faculty members Tricia A. Mason and Professor Esmeralda Uwola to connect with and assist marginalized communities in Portland, Maine. Overall, collaboration between the students and faculty enabled the creation of 15 fleece snow blankets with laminated note cards that included inspirational messages and community resources, which were delivered to a homeless day shelter and food distribution center named Preble Street to support local people in need. So to make this happen, as a group, we developed a grant proposal to receive funding for this project, collaborated over Zoom to make the grant proposal and to formulate a plan to make the blankets and note cards. To make the blankets, we all met at UNE's Portland campus, and then we delivered these supplies to Preble Street. And from there, the center staff then distributed the blankets and note cards to their consumers, those suffering from mental illness, homelessness, and addiction.
Laminated note cards included local contact information and resources to Portland, Maine. This included affordable food resource programs and food shelter locations, addiction helplines, resources for individuals under the age of 18, homeless shelters and affordable housing programs, and the Milestone Foundation Recovery Center. These cards also included words of affirmation to help the individuals who received the bags get through tough times. An example of the affirmations mentioned on the cards included believe in yourself, you are braver than you think, and the sun will rise again tomorrow.
To make this project possible, we worked with multiple different organizations. For example, the Donation Center team at Preble Street Shelter, Joanne's Fabric Store for the blanket supplies, and then multiple faculty at UNE. As mentioned before, we worked with Tricia Mason and Professor Uyoa, and also Shelley Conrad.
So we, as a group, decided to do this project more independently, which allowed a lot of these blankets to be done on students' own time. This was beneficial as the hefty workload students often have didn't affect the completion of the project. Next time, I would definitely recommend more concrete deadlines and more time management skills, as I feel like the wish-washy of everything made group participation a little bit more difficult to achieve. However, overall, we are so happy with the results and how everything turned out. And I know that a lot of individuals in need have been helped. So I'm very happy about everything and how it happened. If you guys have any questions, please reach out. Sadly, because of class scheduling, we weren't able to make it to the event.
but our emails are listed in the PowerPoint and we will get back to you as soon as we can. Thanks everyone, have a great day.
All right, let's go ahead and we'll get started. So our first presentation today is the Blanket Project, Building Community Through Comfort. And if you can't hear at any point in time, please stop me before it gets to the whole video.
Welcome to all the members of this CECE event, including the interprofessional student and faculty involvement. This is the Blanket Project, and we worked on building community through comfort.
This collaborative service learning project involved a team of Bachelor of Science and nursing students from UNE's Portland and Biddeford campuses with the assistance of faculty members Trisha A. Mason and Professor Esmeralda Uwola to connect with and assist marginalized communities in Portland, Maine. Overall, collaboration between the students and faculty enabled the creation of 15 fleece snow blankets with laminated note cards that included inspirational messages and community resources, which were delivered to a homeless day shelter and food distribution center named Preble Street to support local people in need. So to make this happen, as a group, we developed a grant proposal to receive funding for this project, collaborated over Zoom to make the grant proposal and to formulate a plan to make the blankets and note cards. To make the blankets, we all met at UNE's Portland campus, and then we delivered these supplies to Preble Street. And from there, the center staff then distributed the blankets and note cards to their consumers, those suffering from mental illness, homelessness, and addiction.
Laminated note cards included local contact information and resources to Portland, Maine. This included affordable food resource programs and food shelter locations, addiction helplines, resources for individuals under the age of 18, homeless shelters and affordable housing programs, and the Milestone Foundation Recovery Center. These cards also included words of affirmation to help the individuals who received the bags get through tough times. An example of the affirmations mentioned on the cards included believe in yourself, you are braver than you think, and the sun will rise again tomorrow.
To make this project possible, we worked with multiple different organizations. For example, the donation center team at Preble Street Shelter, Joanne's Fabric Store for the blanket supplies, and then multiple faculty at UNE. As mentioned before, we worked with Trisha Mason and Professor Uyoa, and also Shelley Conrad.
So we, as a group, decided to do this project more independently, which allowed a lot of these blankets to be done on students' own time. This was beneficial as the hefty workload students often have didn't affect the completion of the project. Next time, I would definitely recommend more concrete deadlines and more time management skills, as I feel like the wish-washy of everything made group participation a little bit more difficult to achieve. However, overall, we are so happy with the results and how everything turned out. And I know that a lot of individuals in need have been helped. So I'm very happy about everything and how it happened. If you guys have any questions, please reach out. Sadly, because of class scheduling, we weren't able to make it to the event, but our emails are listed in the PowerPoint and we will get back to you as soon as we can. Thanks everyone, have a great day.
So is none of the students from the team actually be able to make it here? Is that kind of what happened? But we do have a few minutes if people want to discuss it. I mean, that was a really brilliant idea. If they were here, I was actually going to ask them how they, identify what the needs the people need, like have, and the resources they put on the cards. But any one of you, if you want to share a little bit your experience, maybe participate in something similar in the past, and how you would have solved some of the problems, feel free to chime in.
I really like that they mentioned what they needed to work on in the future. Sticking to a timeline is so important. And if you don't give yourself a deadline, I find that I just will keep on pushing it back. So I really liked that they mentioned that moving forward, they know what they'll do next time. I also think that it looks like it was all nursing students. This could be a really great opportunity to get interprofessional students in it. I'm thinking that while you're tying those blankets would be a great time to be talking and discussing the project with others. So maybe for the future.
Exactly. That's kind of reminded me of the mask making project during COVID time, that right after we shut down the school, and then a lot of us kind of jumped in and making masks. Anyone else want to share your experience? How do you find the local resources, maybe? We've got quite a group here.
Hi, I joined a little late. Sorry, I'm in clinic right now.
Hi, Allie.
Good to see you.
Would you like to share some? So I don't know how much you heard about that presentation. A group of students, they actually made blankets for the local shelter. And then they also sending cards with information, phone numbers and the organizations that people could reach out to.
That's awesome.
If you would like to share some of your experience.
Oh yeah, you mean finding resources for the project? Yeah, our patient was set in Maine. I lived in Maine for my first 2 years of med school, but I haven't been there in almost a year and a half. So it was a lot of Googling for me. And usually like you'll find a website and then there's a link within that website that takes you to another website. So that's kind of what I did specifically for finding. Ours was financial toxicity. So a lot of the like heating resources and, if certain incomes qualify for different things. So on my part, it was a lot of Googling. I wasn't able to drive around and get resources in a more fun way, unfortunately.
So it looks like we have about 1 more minute until we get started. So this would be a great time if anyone would like to transfer to another break room. Now is a great time to do that. Do we have team members present for our next presentation, which is gender affirming?
Yeah.
Okay, great. Okay, I'm gonna go ahead and share my screen. And yeah, if those group members want to introduce themselves, that would be great.
So actually, I want to say the next 3 project is all from this new IPE program. It's called a FIT. So it's basically we're using public health problem solving paradigm and use that in patient-centered care. So a student as a team and learn about the paradigm and also learn how to use that to actually generate a patient-centered framework. So in all the presentations, you will hear the case and then you will see the framework they come up with. And the purpose of generating the framework is actually looking at the patient from all aspects. So not just the disease and not just the individual, but also the environment they're living in, the interactions they have with other people, their social relationships, and then identify what's their needs. So their needs probably not only the medication, but also other things for improve their overall life quality. So hopefully, a lot of you will become more interested after their presentation. And if you are thinking about participating, just contact me directly and we can make it happen.
Hi, everyone. This is Adaptation of Public Health Problem Solving paradigm in interprofessional training, which is FIT. This is a 12-week elective program that's offered to UNE health professional students and undergraduate students in relevant programs, majors such as public health, that are interested more about IPE. So in this program, we learn about public health problem-solving paradigms for one specific case study, and then build a patient-centered framework for that.
We expanded on a case that was initially developed by Carrie Bonart at the University of Louisville and her collaborators. This fictional case is about Taylor Nichols, a 32-year-old transgender female from South Portland, who is establishing primary care and seeking gender-affirming hormone prescriptions. Taylor has not seen a doctor since she was 18 and is concerned about her cancer risk, what vaccinations she may need, and any untreated medical conditions. As you can see, she has a number of untreated medical conditions. She does use hormones that she got from the internet. Her family history is significant for diabetes, high blood pressure, heart disease, and cancer. Her social and personal health factors include some opportunities for improvement that we'll discuss later.
So we chose the teardrop infographic because, as you can see, the individual is at the center of patient care, and there are multiple aspects affecting the patient, such as her community, social networks, and societal factors as well. We highlighted positive factors for her health in green and negative factors for her health in red. We chose to focus for interventions on her asthma and suicide attempt at 16 years old. So we are going to reevaluate her mental health and see how asthma may be affecting where she's living.
These are some of our interventions that are based in Maine. The first one's the Transgender Law Center, which is for life planning documents for transgender communities and also offers multiple resources. Open Door Transgender Healthcare at Maine Family Planning. This is offered in Lewiston and Waterville locations. And it's hormonal transition therapy and monitoring for those 18 years and older. It offers on-site injection lessons and supplies for hormonal injections and some referrals to specialty providers, as well as preventative care and STD testing and treatments.
Given her medical history, we offered up a few medical interventions. So these included some pharmacological interventions such as albuterol inhaler, metformin, Wellbutrin, but we also offered some behavioral interventions as well, such as consulting a nutritionist, referring them to SAMHSA National Helpline, also referral to a therapist or a psychiatrist as well. And then overall, this experience and being part of this IP program was really wonderful for all of us, and we really enjoyed it.
I was just saying all the members are here and feel free with your questions. I see Dr. Segal is here as well.
I really liked how you guys elaborated on your teardrop model. I think it was really important to put the patient in the center. And I think by having that, we have a better understanding of how all of these different factors are affecting her and her overall well-being.
This is a small thing, but I think it was really helpful that you put them in different colors, the positive ones in green and the negative ones in red. That's just good visually.
And also in terms of the intervention, you could actually promoting more positive factors based on the framework as well.
So I'm curious, what were some unexpected barriers that you all noticed when you were finding your research and resources?
Yeah, that's a really good question. And I think one of the things that I took for granted when finding resources is I can just Google things. And that's because I have reliable access to the internet. I speak English, and all of these resources are pretty readily available. And I'm very comfortable on the internet and with a computer. But just keeping in mind that giving someone a list of hyperlinks might not be usable for them, maybe because of a language barrier, or maybe because they don't have a smartphone or a computer. Maybe they don't have a phone at all, so phone numbers maybe aren't helpful, and that's where addresses and person-to-person contact can be really important. And so making sure that you understand the needs of that individual, so you're not just sort of assuming their needs, but then also understanding what strengths they have and what supports they have and whether they have a phone or not, and understanding that so that you can really tailor our solutions to them instead of just throwing a bunch of resources at them that they can't use.
Absolutely. That seems so important. I'm in an elementary school right now doing my clinical, and sometimes you forget even words that, we use every single day are words that kids have never heard before. They don't understand what you're asking. And so if we're putting all these expectations, but people don't have the means or they don't understand what you're saying, what they're supposed to do, you can't even get started. Thank you for sharing.
Yeah, I think a common vocabulary is so important between healthcare providers and not, and then amongst healthcare providers. And that's something that the interprofessional experience allowed us all to see is where do we have a common language and where do we need to make sure that we are using less technical jargon.
So one thing I thought it was interesting your team found about the air quality in Portland area, South Portland, the Portland area. Do you want to just elaborate a little bit on that?
Sure, I can. So our patient had asthma risk, and she was also living in Portland, and we found that there was an EPA issued warning that there was high levels of petroleum around schools, and specifically USM, where she is also a librarian. So we weren't going to suggest that she move, but just make her aware that that may be exacerbating her asthma.
Yeah, that was really interesting. A regular practitioner probably doesn't even have that information. And it was you guys actually found out.
So hi everyone, we're 4 students from the UNE health programs. We're part of different health programs, and today we are here to present our PHIT program, which we all did together. This semester we were part of this program. This is an interprofessional program where we collaborated to create a patient case in order to explore how the social determinants of health and various factors can impact a patient. Our patient today is James, who is an 87-year-old Caucasian male. Can we go to the next slide? Who is a retired educator from Portland and a widowed father of 6. He has a significant past medical history of multiple concussions from high school sports and back injuries from his time in the military and multiple MBAs. He has been experiencing chronic neuropathic pain affecting his entire body since 2013, and since then has been diagnosed with back pain, postherpetic neuralgia, and cardiovascular disease, and has gone through countless medical and holistic therapies, as displayed on the slide. He has been seen by several ER docs, primary care physicians, and pain specialists without any relief. In fact, his pain symptoms have only increased, and he is now experiencing weakness.
Regarding his social life, his wife is deceased due to cancer, and he lives with one of his sons, with the remaining sons living nearby. Due to pain, James is unable to do the things that he once enjoyed, such as walking around Back Cove or playing games with his friends. Since he has to rely on others for transportation, he has a difficult time getting to appointments and purchasing groceries, therefore resulting in poor nutrition due to eating takeaway and fast food.
Okay, so here is an image of our framework that we created for this course, which lays out positive and negative factors affecting James' life and contribute to his current status. We determined that the main problems for James were his access to care, transportation, limited mobility, and function due to his chronic pain and his nutrition status. So we laid out solutions for this case involving opportunities for transportation through local medical and religious organizations, access to healthy meals for meal services such as Meals on Wheels, and suggested telehealth visits to decrease reliance on transportation, as well as additional referrals to other specialists that could help them with this pain from a different angle. We also suggested local community support groups, such as those run by the local chapter of the U.S. Pain Foundation, that could help to connect him to others who experience chronic pain.
So overall, we found that it is important to apply an interprofessional approach to care, as there are many aspects of a patient's life that could be impacting the reason that a healthcare provider is seeing them. It's also important to consider the impact of chronic pain on all other aspects of someone's life and to be aware of local resources so you can refer accordingly. It was helpful to create a framework, and this is something that could be applied to real life patient cases in order to better understand what factors influence a patient's health and what barriers they may be facing.
All right, go through with your questions. This is a really complex case.
I really liked your slide showing that showing all of the different images of the help that you can receive. I think going back to Ben's earlier point about how using common language is really important. I think that just aids in the ability to understand, what factors there are to help your patient.
So a question for the team. So, apparently he would need a lot of help and from different perspective. In your opinion, like what would be the top priority for him?
Yeah, it's kind of go ahead.
Oh, sorry. I was just gonna say, that's a loaded question. There's just so many problems things that are going on, right? So it really, when it comes down to prioritizing things, the way I would have approached it would have been start with what's the most immediately manageable thing, and that would have been kind of just, hey, maybe talking to his current providers and be like, can we switch him to a more telehealth model of practice, because he clearly can't make his appointments because of lack of transportation, and also just the meal services, kind of because those are some of the things that are going to immediately impact his life and his ability to function. Just the fact that he has access to now healthier meals because he is able to get in touch with those organizations that can kind of provide him with the healthier meals that he needs. So fortunately, our patient was someone who, he was a retired educator. He was, so he had like a good level of education, and he was able to navigate technology and, access resources quite well, which might not be the case for everyone else. So just kind of getting him in touch with these people who can get him those resources that he needs would have been the most immediate, I guess, way to solve some of the problems that he's facing.
Yeah, and then to add to that too, I think just considering like what his goals are. So if his primary goal is to live without pain, then pretty much, offering resources in order to tackle that. Or if his primary goal is to walk around Back Cove, then we'll focus on that. So I think, yeah, patient goals would be something that I personally would focus on as well.
Yeah, that's definitely really important. I mean, in our program, we don't have a real patient contact. So that's the part that we could not interview a patient to find out. But in reality, based on the framework and then based on what you guys learned, it's really important to include patient in your team, right? So you could even include the patient to generate the framework, because you do need a lot of information from them, and then really find out what's their priority. That's really important.
I think this case did such a great job highlighting two very large challenges right now in healthcare too. So not only chronic pain, but the struggle of independence, right? Is he safe to live at home? Maybe. Does he need to go somewhere else, but does he not want to? I think those are really big questions right now, and we're seeing that in a lot of places too. Great job, you guys. I really enjoyed that. And we have time for about 2 more questions if anyone else has anything to ask or add. I'm wondering if each team member can share like one major takeaway that they took from this case that they will be utilizing in practice.
Yeah, I think for me, just figuring out like what local resources are available, because I mean, a lot of us aren't going to stay in Maine. So figuring out like what options we have to provide for patients would be important.
Yeah, kind of echoing what Annie just said, especially like, I'm a second-year med student, like chronic pain is something that we're going to be dealing with on a very regular basis. And so kind of just having the options, like I learned that there were so many options to treat chronic pain that were like, just more than medications and like OMM treatments that we learned. So just like navigating all those options for treatment and approaches, and kind of like what the patient is willing to try, and what's kind of like their comfort level, kind of meeting them in the middle. That's kind of my most important takeaway from it.
Yeah, kind of also going off of that, as a public health major, just being aware of available resources in the area and how to connect your patient with someone who, like, maybe you don't know exactly how to help them, but you know someone who can, and just being aware of those options is really important.
I think for me the biggest takeaway I had was just like the importance of knowing your patients well. Like I think like this was a fictional case, but we kind of do a lot about our patients like personal needs and background, and to get back to what Rich was saying earlier about like the order question, right? Like, it's until you know everything about your patient, you're not able to prioritize work and look into all these different situations that you do. So that was just the takeaway.
Mhm. I think a lot of times, only when you become a patient yourself, you understand the struggle. So, just taking time to find the local resources, I think that helps you to understand how difficult it would be for the patient themselves to find the local resources. So I'm glad you guys all did the hard work, and hopefully will be helpful for the future.
In 2021, there were over 9,500 overdoses in the state of Maine, 627 of which were fatal. Fentanyl, a synthetic opioid that is between 50 and 100 times stronger than morphine, was involved in 77% of the deadly overdoses in Maine. Between 2021 and the first half of 2022, there's been a 9% increase in fatal overdoses, with 19% of those fatalities occurring within Cumberland County. Hi, my name is Elise Parker, and I'm a second-year occupational therapy student who served as a team leader for both the Service Learning Opportunity and the CECE mini grant that funded the project. The CECE mini grant was completed in the spring of 2022 by Kaylee McCrory, a second-year OT student, and Hannah Hutchins, a first-year OT student. We were provided support by Jan Froelich, an associate professor in the occupational therapy department, and Dr. Dana Lawham, the assistant clinical professor of nursing. Chris Hall from CECE and Tricia Mason, the director of the Westbrook College of Health Professions Service Learning, assisted with planning, organizing, and executing the service learning project. Research has shown that the first 2 weeks following reentry, an individual with substance use disorder, otherwise known as SUD, is 120 times more likely to overdose than the general public. This project, Partnerships in Harm Reduction, Campus to Community Engagement, was an opportunity to introduce multidisciplinary healthcare students and future providers to the realities, challenges, and stigma that is commonly faced by individuals with SUD within the criminal justice system, to raise awareness, educate, and emphasize the importance of providing quality services to support successful reentry. In order to better understand and identify the specific needs of community members that would support their reentry, we engaged in a focus group with both male and female residents from the Cumberland County Jail. Both groups emphasize the importance of being supplied with materials that fall into 3 overarching categories. 1, tangible supplies such as naloxone or Narcan, fentanyl testing strips, and hygiene products. 2, resources on housing, employment opportunities, and where to obtain additional supplies. And 3, something that would foster a sense of connection within the community. With the financial support of the mini grant, in addition to several local organizations listed in the acknowledgement section, we were able to gather 10 interprofessional students to assemble 200 harm reduction kits to meet the needs of these individuals. Included in each kit was a handwritten card from one of the UNE students who participated in the harm reduction kit assembly at CCJ to demonstrate acceptance, compassion, and hope for those reentering. Additionally, we created 60 wellness kits for the correctional officers at CCJ that included supplies for stress reduction and a handwritten card to express the gratitude that we have for the work that they do and to highlight the importance of their role in distributing the harm reduction kits. This assembly served as an excellent opportunity to discuss the unique role that healthcare providers have in reducing stigma and promoting access to care for underserved individuals within the community. As a result of this project, we increased awareness of harm reduction principles, practices, and programs for healthcare profession students. We emphasized the relevance of the continuum of care, social determinants of health, and providing client-centered care for future healthcare professionals. And we supplied CCJ with 200 harm reduction kits and 60 correctional officer wellness kits to support resident reentry success. Do you have any questions?
Really interesting project. So I just wondering, do you guys have any follow-up? Was there any individuals who received the kit, or was he in the focus group?
You know, that's a great question. I'm not sure if Chris Hall is in here and if she has any updates. What we do know is that these kits were handed out specifically to individuals who, the individuals at Cumberland County Jail who helped us make these, they're in charge of distributing them. So they're identifying those who would benefit most from them and handing them out. But we have not heard any updates so far as I know.
Mm-hmm.
We do know.
Oh, sorry. I just wondering, is this going to be a continuation project? Is there any other student kind of pick up the project?
Yes, so the goal is to make this a project that would be sustainable. We actually have a meeting tonight to discuss further grant proposals. So if anyone is interested in that, please feel free to reach out to me. We would love to add you to our crew. But yes, the goal is to make this a sustainable project.
Talk a little bit about your experience in working with a law enforcement sort of agency through the Cumberland County Corrections. I know the working relationship between harm reduction and law enforcement has sometimes been a little bit tenuous. And I think this is a great environment where you're interfacing with law enforcement in a setting where there is not incentive to make drug arrests or to prosecute. But can you tell us a little bit more about that experience?
Absolutely. And that's a great question. So we work both with the MDOC, so the Maine Department of Corrections, and for this project specifically, we were with Cumberland County Jail. And there's a pretty big difference between working with prisons and then working with the jails. UNE has a great relationship with Cumberland County Jail because we supply them with so many other service learning opportunities. And we were fortunate that there were individuals at Cumberland County Jail that were really excited to get this project started. They had had naloxone in their possession for months, maybe years on end, waiting to get this project started. So there were a few individuals that were very excited about it. Our idea for creating the wellness bags was how we wanted to get the correctional officers on board with what we were doing. We really wanted to highlight that the handoff, the giving of the bag is an excellent opportunity for connection. And so we really wanted to stress to them that we appreciate the correctional officers. We know that they're doing very hard work and that they're putting in a lot of effort. And we want to make sure that they're feeling as though we appreciate them and we acknowledge their hard work and that they're able to hand it to the individuals re-entering with kindness and compassion as well.
I think this is a really phenomenal project, and I'm glad to see folks from across our programs working on it. This is something I would be interested in helping to support as a faculty member. I have some contacts with Portland Overdose Prevention and Church of Safe Injection that we actually engaged in our state PA conference this year. And it is a big area of personal interest for me. I think the folks approaching our substance use disorder epidemic from a harm reduction perspective really have the right perspective and are really onto something with how they're approaching some of these problems from a patient-centered perspective.
Well, thank you so much. We would love to have you on our team.
So I would just like to add that we've been working very hard with the Maine Department of Corrections to develop a strong relationship. And if you are interested even further, we will be hosting a knowledge exchange and a follow-up conversation cafe. But what I really want to say is that they have developed what they're calling a humanistic approach to working with people who are incarcerated. And it's a very different approach, as you probably know, Chris, from other states or other programs. They are working to create relationship with people who have been terribly marginalized and basically invisible. And that's not to excuse people for crimes they commit, but to recognize that everyone needs to be treated as a human being. So they're going to be presenting And then the following Monday, we're going to follow it up with an in-person conversation, which will include folks who will be on the panel. So I'm hoping that many of you will participate in that, and don't worry, we'll let you know when it's happening. We're good with that.
It is March 1st, and I've dropped the information in the chat for everybody.
There we go.
Everyone really did excellent job, and then nice working with all of you.